have your stuff from last year too. So
Okay, cool.
there's always that. So don't feel bad at all. But it's all gem. It's all gems and
Yay.
amazing stuff. So
Yay. Okay, guys.
yeah.
EKGs. EKG day. All right, so this is a normal EKG. I wanted to just show it what it looks like. All EKGs are different. Everyone's EKG looks different. A little clinical like pearl when you're doing rotations, when you're seeing a patient, they give you an EKG, always ask for what's this patient's baseline, because some people just have that can have normal EKGs, but it can be like normal for them, but it might look a little off. So that's just always like a thing. Like every EKG can look a little bit different. But with that being said, there are some things that are like always going to be wrong. So this is a normal one. We're gonna go into this, but I always look at lead two. And we'll talk about why you always look at lead two, not just like look at lead two. It's the best one. We're actually gonna talk about why. But usually with EKGs, they show you like lead two like right here, and then at the very bottom of the strip, there's usually an entire strip of lead two, and that's why, because you want to look at it. All right, basics. So we're going to talk about electrical conduction. So we did talk about this, yes. Well, I talked about this yesterday. It's going to be in the PowerPoint on the electrical conduction system. I kind of went into a lot of detail about that. But that's basically what EKGs are doing. And with the antiarrhythmics, I talked about, and Riley, you should know this, but Vanessa, I didn't really talk about this with you yet because this is in the video. One action potential for a cardiac myocyte looks like this. This is like the action potential of a single cell. Like sodium flows in, then it's potassium, then potassium and calcium, and then potassium. This is one single cardiac myocyte. An EKG, you can kind of think of it as like the depolarization of hundreds of thousands. That's not a great EKG, but it's hundreds of thousands of cardiac myocytes. So kind of like that's why with antiarrhythmics, you can kind of see changes on the EKG and it's going to tell you what's going on with like the actual individual cardiac myocytes. Okay, so that's kind of the whole point of it, is to assess what's going on with all of the individual cardiac myocytes at once, because it all happens all at once because of those gap junctions. But okay, so this is kind of how I explain EKGs, because I think it helps make sense of like the actual like which way the lines are going. So kind of how to think about it is the myocardium, so where all those muscle cells are, usually at rest, they're polarized. So that means that the inside is going to be negatively charged, the outside is going to be positively charged. Hopefully that makes sense, because that's how, when the ions start flowing, that's what causes contractions. Depolarization moves in a wave. And I put recall here because I felt like this was like a common thing from first year, but I feel like some people just don't know this, which is fine. But depolarization moves in a wave. It goes from the endothelium to the endocardium to the myocardium to the epicardium. And you can think of this kind of as like, as it's moving from the endo layer to the myo layer to the epi layer, like electrically what's happening, it's going from the SA node to the AV node to the bundle of His to the Purkinje fibers. Repolarization moves in a backwards direction. Repolarization, when the heart becomes repolarized, it goes from the epicardium to the myocardium to the endocardium. So we have like this wave of depolarization out, and then we have this wave of repolarization moving back in. And I'll help you guys see this visually, but I think this is going to help make sense of a lot of the EKG stuff. All right, so quiz. So I didn't take this off on your guys' version, but don't look at it. So what's happening here at the P wave? What does the P wave represent?
Depot of the atrium.
Good. Awesome. What does QRS represent? Riley? Next. Good.
Ventricular depolarization.
Or
It also is the
depolarization.
yes. Just wanted to throw that in. I don't even have it on here, but okay. And then the T wave is going to be your ventricular repolarization. So you know that atrial repolarization is hidden by the QRS complex. And then this is what you're going to get inundated with this when you watch the antiarrhythmic video. But this is just like an absolute need to know. You need to know the contractile cell action potential. You need to know the nodal cell action potential. But we're going to be talking about this one because this is what comes up on an EKG. Like this is what lines up with your EKG, is what's happening with the contractile. So this is an individual contractile cell. So with depolarization, basically what's happening is we're going from around like -60, -70. No, it's -70. No, this is -90. Okay, so we're going from negative up to positive. So we're going from a negative to that's depolarization. And that's when sodium comes into the cell. So sodium enters the cell. So it's something positively charged entering the cell. So now it's going from negative to positive. So how I explain like depolarization in terms of EKGs, think of depolarization as making cells just more positive. Like I'm making the cell more positive. That's what depolarization is. Repolarization, this is going from like a positive value to a negative value. And this is because potassium leaves the cell. So potassium's going to leave the cell. Now I'm at like a positive 2, and then I'm going to go back down to like, negative 90, negative 70, whatever. So repolarization, think of repolarization as making cells more negative. So depolarization, we're making cells more positive. Repolarization, we're making cells more negative. Okay, and we're gonna revisit this fact. We're gonna talk about electrodes because a lot of the times we're talking like, oh, lead 2 is the best one to look at, but we're going to talk about the electrodes a little bit more. So there's 6 limb leads and then 6 precordial leads. So the 6 limb leads, these go on your limbs. So it's 1, 2, 3, AVR, AVL, AVF. Those are the 6. And then you have your precordial leads. These are your chest leads. They go in your chest. So that's V1 through V6. And when you combine these like 6 each types of leads, you get a 12 lead EKG. So that's like your standard EKG. All right. So how all of these limb leads and precordial leads, how they detect electrical signal is they themselves are either a mix of positive and negative electrodes, or they're just positive electrodes or whatever. They're like the limb leads, for example, these are both positive and negative. So one side is negative, one side is positive. Precordial is just positive. It's just one positive lead. And that's why with the precordial leads, you just kind of like, if you've ever seen an EKG be given, you kind of just like pop it on the patient's chest. It's just one thing versus the limb leads. And I have pictures of this to show you, but just to kind of help visualize, it's like you're anchoring it with one side and then you're putting the positive end somewhere else. And that's so it's kind of like it's connected like this. So with that, how this is going to detect electrical signal is, so we already talked about how a wave of depolarization is making a cell more negative, right? So let's say we have this wave of depolarization or a wave of positive charges going towards a positive electrode. So we have positive charges moving towards a positive electrode. That's going to look like a positive deflection electrically. On the EKG, it's going to look like a little upwards like deflection. But just like having a positive go towards a positive, so we have a positive go towards a positive, makes an upward deflection. If you have a negative go towards a negative, so remember I said like these limb leads, there's one negative end, one positive end. So let's say we have repolarization, which we just talked about how repolarization, you can think of it as making the cell more negative. We have negative going towards negative. So like from here to here, that's also going to look like a positive deflection. So I always think of like a positive deflection as like towards like. This only gets tricky with like the, because a lot of the times there's not really like a negative electrode they'll mention. It's kind of just like, it's just kind of, it's anchoring, I guess, because the positive electrode is the one actually detecting what's going on. So a lot of the times they'll say like, oh, repolarization, it's like these negative charges moving away from a positive electrode. And that's just another way that they can word it. But I always think of it as like towards like. So positives going towards positive, it's positive deflection. Negatives going towards negative, or technically away from positive, whatever, it's negative towards negative, positive deflection. Okay? So to visualize this, because that was just words. So remember at rest, we have the cells are polarized normally at rest. So here is here's like some cardiac cells. So we have negative and then positive, like we have the black are the electrodes. So like let's say here's a negative electrode over here and then a positive electrode. This would be like lead 2 or like lead AVR or something like that. So what's going to happen is at rest, there's no movement of charges. So there's absolutely nothing happening, even though there is polarization, there's no movement of charges, right? Because again, depolarization is this wave of movement. Repolarization is a wave of movement. So the EKG is going to look flat. When we have our wave of depolarization, it's going to be, and this is happening, usually it happens all at once because of those gap junctions, but you can think of it as, if you really, really slow it down, it looks like this. One cell gets depolarized and the next one gets depolarized and the next one and the next one. So this is a positive charge because we have depolarization occurring, moving towards a positive electrode. That's going to be a positive deflection. If once the cells are all fully depolarized, so again, remember this is like an actual movement of charges. That's what's causing that positive deflection. Once the cells are fully depolarized, so there's no more movement of charges, even though like, yeah, they're depolarized, like they are positive, there's no more movement of charges, it's gonna look like a flat line. Okay, and again, just we're gonna go into this in a lot more detail, but just keep all of this in mind. Now, if we wanna like mimic repolarization, we can't really mimic repolarization because we can't stimulate a negative electrode, like, but to kind of visualize it, what if we stimulate cells at the positive end? So like, let's say we stimulate cells here. Now we have positive cells moving towards the negative electrode. This is positive charges away from a positive electrode. So that's not going to be a positive deflection. That's going to be a negative deflection. And then finally, if we have repolarization occurring, I didn't have the little animation, but repolarization is this moving to this, like we're moving towards the negative electrode. This is going to be a positive deflection. Okay. So if we have our little EKG diagram, we talked about how this is atrial depolarization. You can think of atrial depolarization as positive charges moving towards a positive electrode. QRS, ventricular depolarization, this is positive charges moving towards a positive electrode. And then for our T wave, which is ventricular repolarization, you can think of that as negative charge moving towards a negative electrode. Okay, so kind of thinking about what all these little deflections mean in terms of the movement of the charges. Okay. So then these are the limb leads. So just like I said, the bipolar leads are going to be your 1, 2, and 3. So here is a negative to a positive for lead 1, negative to a positive for lead 2, and then negative to a positive for lead 3. And then your unipolar leads, these just have like one positive end. So it's just it's just one single positive charge. And then the precordial leads look like this, and it kind of shows you the views. And we'll talk about this because you do need to know, like, if you have an MI in like V1 and V2, you need to know that you're looking at like the septum. So we'll talk about that. I have like a mnemonic for that. But this is just kind of showing why. If you put it on the heart like this is why you see the different views of the heart. Okay, so we're going to construct our own EKG basically. So we're going to go through the electrical conduction of the heart. So this is the diagram that I used from PowerPoint, and then I labeled where all the things are. So the first thing that happens, SA node sends an electrical signal to the AV node goes to the bundle of His, the bundle of His goes through the bundle branches to the Purkinje fibers, and then the Purkinje fibers do the rest of the ventricles. If you think about this though, the overall vector of charge movement is top right, because this is right, and then this is left. So top right to bottom left. And again, it's just because like if you add on, this is very physics, but if we're not going to do vector analysis, but if you were to add all of the strength of these arrows up, even though we have some going straight down, some going straight up, overall the movement of charge is from top right to bottom left. Okay. Do any of the limb leads line up with this vector? So do any of these guys line up with that beautiful overall electrical vector? Yes, lead 2. So lead 2, remember it's put top right shoulder and then it goes to bottom left. And that's why on here, it's like this. You can see, I mean, it's not beautiful, but it's like on the right shoulder and then it goes to like the lower left part of the body. And that's why, again, people look at lead 2 because it lines up beautifully with this vector of the heart. Okay, so that's why I always say when reading an EKG, always look at lead 2 first. That's going to give you like the most, like what's going on with the electrical conduction of the heart, just like at like a first glance type of thing. So during one cardiac cycle, lead 2 should tell you what's going on electrically. And that's what I was saying earlier. There's almost always a lead 2 reading along the entire bottom of EKG. It's because it's like the best lead for this purpose of like trying to assess what's going on. All right, we're constructing an EKG. So I didn't use the little heart thing. I made the heart a box, a series of boxes. And I shouldn't have made it red because I forgot like this is red, but that's all right. We're going to see what we can do. So right atria, left atria, right ventricle, left ventricle, SA node, AV node. I don't have the bundle of His on here, but it's like right here. And then the bundle branches, and then the Purkinjes aren't labeled, but you can figure it out. All right, so the very first thing that's going to happen, I have to put my lead 2 on. So here's lead 2 because we're looking, the EKG that we're constructing is from a lead 2 perspective, right? So the first thing that's going to happen is the SA node is going to generate an action potential. So overall, it's going to depolarize, and it's going to send that signal towards the AV node. So how is this going to look like on an EKG? It's going to look like a positive deflection, right? Because we have this wave of depolarization, this wave of positive charges moving towards a positive electrode. So positive charge towards positive electrode, upward deflection. So that is what's known as your P wave. The second thing that happens is the AV node sends like a little tiny little vector from the AV node to the bundle of His. Remember at the AV node, there's tons of slowing down that occurs anyway. It's not a very strong signal. Its purpose more so is to just slow down actually the electrical signal from the SA node. So it doesn't really send that strong of a signal. So even though it's not like, it's like kind of perpendicular-ish to the lead 2, it's just going to look like a flat line. And that's what's kind of like your PR segment is basically like traveling through the AV node. And that's why it's just flat. It's not strong enough to kind of have this big deflection or move in any sort of direction. Okay, so that's your PR segment. Next, we have the bundle of His depolarizing. So the first thing that the left bundle, this might just be like a fact that was in Klabunde, but the left bundle branch actually depolarizes before the right bundle branch. And like Klabunde thinks it's because like the left ventricle obviously is a lot bigger. So like the heart wants the left bundle branch to be like, hey, let's make sure it's set before we depolarize the right side. So the left bundle branch actually depolarizes first, and it sends its positive charge towards the direction of the right bundle branch. Okay, so how that looks, so think about how this is going to look. We have like this wave of depolarization moving almost exactly in the opposite direction of lead 2. That should be a negative deflection, right? We have a positive charge moving away from a positive electrode. So that's your Q wave. And this is what I'm talking about. Like Q waves can be different sizes in people. Some people might not even have Q waves because it's like, it's not strong, like it's not happening. It's like the little idiosyncrasies of people. Some people's left bundle branches might not depolarize before their right bundle branches. So it's just like one of those things. Like if there's no Q wave, it's not a big deal. If there's a really deep Q wave, that might be like, oh, maybe there's, there's left ventricular hypertrophy or something like that. But that's what's causing this negative deflection, is this positive charge is kind of moving away from the general direction of this positive electrode. Okay. So next, after the right bundle branch gets depolarized, now it has to go to the Purkinje fibers. So from here, since the left ventricle is a lot bigger than the right ventricle, because now again it's sending like depolarization signals both directions, so both are still happening, but the left is a lot stronger than the right's because the left ventricle is a lot thicker than the right ventricle. So this vector is going to predominate over the right bundle branch's vector, and so it's almost beautifully lined up with lead 2 at this point. So that's going to be your R wave. So that's your positive deflection. We have a positive charge moving towards the positive electrode. That's going to be an upward, like a positive deflection. And then, oh yeah, my clinical correlation is, this is, at this step, the R wave basically is trying to depolarize, like, basically, I mean, it's trying to get to the Purkinje fibers, but it's just trying to depolarize that entire left ventricle. So when it's doing this, you can imagine if someone has left ventricular hypertrophy by definition, you guys have all done chapter 1 of pathoma, you know that just means the cells are thicker, like there's just thicker cells. So you're going to imagine there's got to be a stronger signal for them to now depolarize. So you can see really, really tall R waves, and usually that's an indication of like left ventricular hypertrophy, because now the left bundle branch has to send an even stronger signal over to like all the hypertrophied cells in the left ventricle. So cardiac hypertrophy will create like a very large deflection here because increased thickness, more cells depolarizing, higher R wave. And then this is like another one of those things. It could be normal, and that's what it's like. You want to look at someone's baseline EKG before seeing what's abnormal and what's not, like what's normal, what's not normal for them. Be like, oh, that's normal for them. Like normally they have left ventricular hypertrophy, so it's fine. And then finally, we have the chargers kind of running up the Purkinje fibers. So when the chargers kind of run up the Purkinje fibers, it's like not perfect, but it's not beautifully like away from the positive electrode, but it's away enough. Like it's kind of like over and up, where the EKG is going to read this positive electrode down here is going to basically read this as like another downward deflection, another negative deflection. Because this positive charge, it's not perfectly away from this positive electrode, but it's enough where it's gonna be read as a downward deflection. Okay. And then finally, we have repolarization. And remember, repolarization now is going to move in the opposite direction. So we went from here out to here. Repolarization happens from the epicardium, myocardium, back to the endocardium. So now we have repolarization. These are negative charges moving towards a negative electrode. So that's going to present as a positive deflection. That's your T wave. And then between steps 5 and 6, basically, so right here, so when the Purkinje fibers are sending that wave of depolarization, what's being read as like this downward deflection, and between this wave of repolarization, there is a time period where the ventricles are completely depolarized. And remember, we talked about that when you have complete depolarization, there's no movement of charges, nothing should be happening on the EKG. That's your ST segment. And I'm going to bring this up later when we talk about STEMIs and NSTEMIs, because this is actually really important in understanding their path, like the pathology of what a STEMI is, what an NSTEMI is. So you have to think of like the ST segment as being like just that's basically complete full depolarization of the ventricles. And that's why it's a flat line. Okay. So here's kind of, I took the little drawn EKG and then I color coded it with what's going on and how we get all of these things. Okay, so everything we kind of talked about. Make sense? Cool.
How do you have time for all this, girl? Like, honestly. Oh, great.
But really like EKGs. Really, really like them. Really love them. So this is lead 2. Like I said, this is what we just basically looked at. And so all of lead 2 should pretty much look the same, but just keep in mind those little idiosyncrasies. Like even in this guy, he doesn't have like a great Q wave or an S wave. It's not a big deal. It's like not really like something to be too concerned about. It just might be normal for him. And then this is like a need to know. I gave you my little mnemonic for how I remember it, and I'll show you. I have some questions at the end that I kind of just made up because they can tie these leads into like heart dominance or like stuff like that. Like they can bring those concepts back in from like first year. So you do need to know like inferior leads. If you want to see the inferior part of the heart, the inferior leads are 2-3 AVF, mnemonic 2 to 3 feet. And then feeder at the bottom of the body, fine. Lateral, this is 1, V5, V6, AVL. One hand, 5 to 6 fingers, and then fingers are lateral. Anterior leads, V1, V2, 1 nose, 2 knees on the anterior, and then septal leads, V3, V4, 3 to 4 boogers in your septum. So these are need to knows. And then kind of if you wanted to like more so visualize it, like I don't know how visual how you guys are, but like this is where all the kind of leads are grouped together. So your inferior leads are here, your anterior and septal leads are here, and then your lateral leads are like over here. Okay. So now that we went through EKGs, the basics of them, EKG, so answering EKG questions, and this is true for your exam, this is true for boards, they will usually, and I wanted to say never, but you know, never say never. But they will usually never ask you to like just straight up interpret an EKG. Like they'll never just like give you an EKG and be like, what's going on with this patient? Like they're not going to do that. They'll give you some sort of vignette. They'll give you something. The EKG will just be like a supplement. There are some obvious ones where they straight up can just be like, what is happening with this patient? And those are the ones that we're going to go over next. So like those obvious ones. And I put all the ones that I got asked on boards. Comlex didn't even ask me a single EKG question. It was all STEP that asked me EKG questions. But they even asked just very, very basic EKG questions. So like a classic example, and this is what I tried to do at the end with questions that I like came up with. So it'll say something like, okay, there's ST elevation seen in leads 2-3 AVF. Where's the infarction? So you know, like, oh, leads 2-3 AVF, those are the inferior leads. It's got to be an inferior heart MI. Or they can be like, okay, these abnormalities were seen in 2-3 AVF, which artery is blocked? So that's going to be your posterior descending. Or they tied into heart dominance. So you should know, like, okay, the PDA in 90% of people gets fed off of the RCA. So this is like an RCA, like, question. You know what I mean? And like I said, sometimes they will also just show you an EKG instead of saying, like, oh, ST elevation seen in 2-3 AVF. Sometimes they'll just show you it and you have to pick out, like, oh, yeah, here's 2-3 AVF, there's ST elevations. Usually it'll be obvious, like, what they're trying to do. They'll be very, and I'll show you, like, the STEMI, like the 2-3 AVF STEMI EKGs. Okay. And then the other thing I wanted to mention, because this does come up, I think this came up on my, at least my exam, heart rate. So without, like, being told what the heart rate is, like, they just give you an EKG and you can determine what the heart rate is. So I don't know if you guys have heard this trick. This is straight from Boards and Beyond. So try to find, like, an R wave that's exactly on one of these lines. So just try to find one as close as possible to being on one of, like, these lines. And you can look on any lead, so it doesn't have to be lead 2. It can be literally any lead. And then count how many of these big boxes. So I know, like, there's some ways where it's like, oh, you can count these little tiny boxes in between the big boxes. I find this way is, like, just works just as well. So count how many of these big boxes are in between the 2 peaks of, like, the next R wave. So here's an R wave, here's an R wave. There's 1, 2, 3, almost 4. So, like, 3.5 in this patient. And then you do 300 divided by how many of these boxes there are. So it would be like 300 divided by, like, 3, almost 4, and then that's your normal heart rate. Normal heart rate 60 to 100. So if you're, like, between 3 and 5 of these big boxes, you know that the patient has, like, a normal heart rate. And you'll see, like, tachycardia, they're gonna be a lot closer together. Like, that's why, and that's also why on, like, the arrhythmia video yesterday, I was talking about, like, look at the distance from R wave to R wave. That's going to tell you, like, what their rate is, how, if they're having a tachycardia, if they're having a bradycardia, whatever. Okay. So it's just, like, a fun thing. All right. Important EKGs. Okay. My favorite thing to talk about, because I feel like people don't understand STEMI versus NSTEMI. And granted, I didn't either. I was actually listening to a podcast, and that's when I learned what these were. So,
The Goljon guy, whatever.
no, not him. His name's Divine Intervention.
Right there.
He's really good for step 2 stuff, but I started listening to him, like really close to my boards, and he explained what STEMIs and NSTEMIs were, and my mind was absolutely blown. So I wanted to share the love. But what's most important about STEMIs and NSTEMIs is basically, like, understanding, like, what an ST segment is. And we talked about what an ST segment is. It's when the ventricles are completely depolarized. Yeah, your minds are going to be blown. I'm really excited because I don't think people realize it. So STEMI obviously stands for ST elevation myocardial infarction, and STEMI non-ST elevation myocardial infarction. Doesn't have to be a depression. Usually it is, but it's just not elevated. So it can also just be normal, and that's an NSTEMI if they're having, like, an active MI. But again, usually, yeah, there's an ST depression. All right. So a STEMI, and we'll talk about the mind-blowing aspect of it next, but before we get into that, you have to understand a STEMI is a complete occlusion. So again, this is from Boards and Beyond. So with this, like, there's a plaque that forms, like, a clot, just something happens where, like, one of the coronary arteries that's supplying the heart that would be picked up with an EKG completely blocked. So when you have complete occlusion of, like, one of the arteries, and, like, on this, let's say that this is, like, let's say this is, like, the PDA, right? So let's say this is the PDA. So this artery is right here. This little circle is this artery. So it's completely blocked. And that's why they say, like, the first part that becomes ischemic is always going to be the furthest away from the blood. So the endocardial layer, which is the innermost, is going to be the one that's going to go first. But since we have complete occlusion, the myocardial layer goes and the epicardial layer. There's just everything that's supplied by this vessel dies. So this whole area dies because there's no blood flow going into it. That obviously would cause an MI. And if this was an inferior wall MI, 2-3 AVF would be elevated. And since it's a complete occlusion, you'd see ST elevations in 2-3 AVF. Okay, so does this make sense? We have transmural ischemia, which means it goes through the entire thickness, endocardium, myocardium, epicardium. All 3 layers are going to be completely ischemic here. And it's because there's absolutely a complete occlusion of one of the walls, okay? This is so a STEMI, because like we have this complete occlusion, this is your active and ongoing MI. This is like when someone is like I have chest pain, like my arm hurts, like that whole thing. That's what's going on. And it's the transmural ischemia happening. Not only, like, it doesn't always have to be a complete occlusion. It can also be like Prinzmetal's vasospasm or Prinzmetal's angina. Remember, Prinzmetal is total vasospasm. So it's kind of like, imagine that this artery now didn't have a blockage. It just, for whatever reason, starts spasming, and then it completely just closes. And this is not showing a good picture, but imagine there's no blood flow that gets through. It just completely blocks blood flow. That can also cause a STEMI because it's complete occlusion of a vessel. And the only way to treat this is you can't even give like a blood thinner or anything. You have to get rid of this clot. Like, you have to basically do PCI therapy. So like percutaneous coronary intervention, you have to put a stent in there. All right, mind-blowing part. So with a STEMI, technically the ST segment is technically not elevated. So even though it's an ST elevation MI, it's not actually elevated. Everything else is just depressed in reference. So if you think about it, this is your normal baseline of like if we were to have like a normal P wave, QRS, and then T. I'm really bad at drawing these. So this would be like your normal baseline for like this person. With an ST elevation, myocardial infarction, the ST segment is going to just appear higher. It's just going to be higher compared to the normal baseline. So what this basically means is if you have transmural ischemia, and this is like what I was explaining, Riley, I think you would have gotten there because you only have 30 minutes left of yesterday's PowerPoint. I was saying, like, we can go back through the basics of like what happens when you have ischemia, like what happens to the cells like at rest. If you have transmural ischemia, so complete, and that's what this blue is showing, like complete ischemia through all three layers, and this would be like lead 2, like the positive end of lead 2. The baseline is going to be basically lower than the rest of the EKG baseline. So this part of this transmurally ischemic part of the heart is more negative now to start because the tissue is completely dead. Okay, so basically it's like to start, here's your normal baseline. Let's just use this one. This one has the dotted line in there already. Here's your normal baseline. And then to start, because we have transmural ischemia, so complete total ischemia, little hint, it's going to be different from not transmural ischemia. But transmural ischemia, when every single cell in this little segment is dead, it's going to start lower than normal baseline. So maybe instead of being like -70, it'll be like -90 or -100. Okay? So this blue, now it's starting down here, and then it undergoes normal depolarization. You know, it's going to go from like the atrial depolarization. Ischemia causes more depolarization. Yes, for subendocardial ischemia, not for transmural, when the actual tissue dies. Yeah, I know. It's like easier to do the NSTEMIs first, but it's funner to talk about the STEMIs. Yeah, and that's what I was talking about. So like the class 1B antiarrhythmics, those preferentially bind to already depolarized tissues. Those are better for your NSTEMI MIs. And like I said, you don't give an antiarrhythmic for a STEMI MI. You can only do percutaneous coronary intervention. That's why. It's because it's like the cells are dead versus like an NSTEMI, which it's not going to be. They're not going to all be dead. They're actually going to be closer to depolarization, and that's when you can give a class 1B antiarrhythmic. Okay, so tying it all into the antiarrhythmics, which you're going to do next, Vanessa, but it'll make sense when you get there. You'll be like, oh, this is what she was talking about. So with this, we have transmural ischemia. They're totally dead. Baseline's going to be a little bit lower compared to the normal baseline. Now with this heart at this segment, it's going to be lower. Normal depolarization occurs, and remember, when we have full depolarization, which is like the blue, like just complete, everything's now depolarized. That's what the ST segment is. The ST segment is going to be where it should be normally, like at the normal baseline level. But then it goes back to the more negative baseline because of this complete ischemia. It's causing like this more negative baseline. It's just like I say, it's just a feature of complete ischemia.
So can I just make sure that I get this?
Yes.
So we're saying baseline, we're lower because we have dead tissue.
Mm-hmm.
It's more negative because it's more dead.
Yes. There's like, just think of it, it can't contribute because the tissue's dead, right? So it can't even contribute to the charges. Yeah.
They're all flat.
They're just dead.
They're just dead. So we're generating a current that's going to sweep through the tissue.
Mm-hmm.
It has to be more because we have just complete deadness in this segment of the tissue in the heart. So that's why we have a depression at baseline. It's lower at baseline, has to be elevated more than it would normally. So everything just shifts upward. And that's why it looks like an ST elevation, but in fact, it's just
The
rising
baseline's
up
lower, right?
higher. Now, in relation, the ST segment in relation to the QRS, it's not like comparing those values, they're not very different. So that's also showing you that like there's not a lot of activity going on there anyway, but everything is just lifted up.
Right, because remember the ST segment is full depolarization, no movement of charges. That shouldn't change. Like that really shouldn't change with something like a complete occlusion because the rest of the heart's just going to get depolarized anyway.
Got you. Yeah.
Exactly. See, isn't it fun? Isn't it fun? See, it is a fun fact. And they'll never ask you about this, but it's good for you to know. Like it's good for you to be like, wow, like I understand what's happening.
Papa will ask in class. Maybe not in the exam.
Like, it's gonna be like his fun fact or something. He's gonna be like, did you guys know that? And then you're gonna be like, I do know that actually.
Yeah.
Oh, Riley, I knew nothing about EKGs until boards, like before, like until dedicated. So I didn't even go through this block last year, like or second year, like understanding this. I didn't even know this.
No, like going through Boards and Beyond again, I'm just like, wow, this makes so much more sense
That's
now.
how I felt. Yeah, that's how I felt. That's exactly how I felt second year. I was like, wow, this actually makes sense now. I'm like, wow.
What happened? Yeah.
The other thing I want to mention about STEMIs, because we're going to talk a little bit about angina, just like a little baby bit. With STEMI and NSTEMIs, you're always going to have elevated cardiac enzymes, and that's like your true feature of an MI. So these are both MIs. So STEMI and STEMI, even though like what's happening is different, they're both still myocardial infarctions. There's still loss of oxygen to the tissues. So you're going to have elevated cardiac enzymes, and a lot of the times you can't really differentiate between like NSTEMIs and unstable angina. You just can't do it, and that's one of the ways that they'll help you be able to differentiate. Is they'll give you either there's elevated cardiac enzymes or there's not. So like troponins will be elevated, CKMB will be elevated, AST, LDH, things like that will be elevated in a true MI. Okay. And STEMI, so back to here, so like let's say we're looking at the PDA again, so like this artery is technically this little hole right there. Let's say it's subtotal occlusion, so not complete occlusion, like there's just not a complete occlusion, but something is causing a very limited blood flow now. So now like the heart, which still needs it needs this amount of blood, but now it's only getting like this amount of blood because of this blockage. So you can imagine the first part that's going to die is the part furthest away from this artery. That's why they call it subendocardial ischemia, because remember I said the furthest away from the artery is going to be the first part that dies. That's the endocardium. So whenever they say there's, subendocardial ischemia, and this is actually in my antiarrhythmic talk yesterday, I reference subendocardial ischemia a lot because that's kind of when antiarrhythmics are really good to give, is when you have subendocardial ischemia. Or like subtotal occlusion. Complete occlusion, you just can't give an antiarrhythmic. It's just a totally different kind of like pathology state that's happening. But it still causes an MI. That's why you're still going to see elevated cardiac enzymes. You'll still have them. But you're just not going to have an ST elevation. You may not even have an ST depression. So you can see an ST depression. You may not have it. Usually you will have it, especially for like from what I've seen from doing questions and stuff. They'll like, if they want you to think NSTEMI, they'll do a depression, or they might do a T wave inversion. So a T inversion, and hopefully that makes sense. You're kind of reversing repolarization. Like now repolarization usually goes from here to here. now it's kind of like it really has nowhere to go except out. And we'll talk about why, because of the subendocardial ischemia. Those cells are already more depolarized to begin with. We'll talk about that in a second. But that's, you can see that, you might not see that. It doesn't always mean, like, if you see a totally normal EKG, but you're like, oh, this person has an NSTEMI, or this person's having an MI, it could be, like, it could be an NSTEMI because of that. Okay. So subendocardial ischemia, the ischemia, because again, you're not losing blood. It's just like the tissue now is not getting enough oxygen as it's used to. So the furthest part away dies. Usually it's going to be like a plaque rupture or a thrombus or some sort of angina that's forming, because, angina is always like a narrowing of the vessels. For this, you can give honestly any of the antiarrhythmics. You can give your class 1Bs. You can give any of the antiarrhythmics that are going to be in that video. Beta blockers are just like, those are your needs, and like you need to give a beta blocker after someone has an MI. You just have to. But you can also give like an anticoagulant and a nitrate, something to kind of help with the symptoms itself. An anticoagulant, you don't want it to happen again in the future, so you would want to put them on like a blood thinner for a little bit. All right, and then this one, the ST segment in an NSTEMI is not technically depressed. So like if it would be like, I always say like, oh, there's ST depressions and NSTEMIs, it's not technically depressed. Everything else is just moved up. So here's your normal baseline. I'm not going to draw it this time because it's confusing. I just do a bad job. So normal baseline, dotted line. So this is normal people have this dotted line here. In people that have subendocardial ischemia, and this is what I was talking about yesterday, which I'm like, this will maybe make sense. We can talk about it in a future session if you guys need. This is what I was talking about. Subendocardial ischemia, the cells are like, they are dead, but it's like this entire area is not dead. So the lead is picking up this entire area. And basically what happens is, and even like I tried to see what Dr. Ryan had to say about it, it's just like, this is just what happens with subendocardial ischemia. These cells now are just in this area are now just more depolarized compared to the area that's completely dead. So if they're more depolarized, this means it's going to be more positive to start. The normal baseline is going to be more positive to start because this tissue is not transmurally ischemic. It has this partial depolarization feature. So we're already closer to normal baseline. Like we're already closer to what's that called? The threshold. We're already closer to the threshold. And then when full depolarization occurs, that's not changing. Everything's going to be the same there. So that's why the ST segment seems lower, because the ST segment is full depolarization. Nothing's changing there. So it's going to be just back at normal because that's what's normal. But everything else, even when it goes back to resting, it's going to go back to that resting partially depolarized baseline. And again, this is just a feature of partial ischemia versus transmural ischemia. That makes sense? Are you guys' minds like blown like mine was?
Yeah, it's like you don't think about it in those terms, but when you break it down in that way, it's like, wow, that's pretty cool.
It's like, wow. It's like medicine makes sense sometimes. Yeah, the ischemia concept it's confusing though. It is confusing though, because it's kind of like, what do you mean? Like, how can cells be different versus one type of ischemia versus another? But it's like the nature. You have to think of it as like on an EKG, it's all the cells in that area. It's not just the ischemic cells.
So it's almost as if the ones that are still alive are inheriting
they're like
all of
flipping
the
it.
current
Right.
that the dead stuff can't
Yeah, they're
deal
trying
with.
to take over, like they're trying to help.
So that's
Especially
why
like
it's
you
like,
have to remember too on these EKGs, this is happening right now. This is happening right now. Like this is not someone who had an MI in the past. Like this is someone actively having an MI right now, type of thing. Well, at least a STEMI is. So it's kind of like there's not even time for like it can't even be like an adaptation. Like the cells are trying to like fix it now, type of thing.
mm-hmm.
Okay, and then yeah, we talked about you're also going to see elevated cardiac enzymes. They're still having a myocardial infarction. Cells are still dying. That's going to elevate the cardiac enzymes. And I bring that up because that's how you can kind of differentiate between like an MI and unstable angina, which again present so similarly. And that's why like when you go to a hospital and someone comes in with chest pain, they bring them back like almost immediately because the first thing they want to test is troponin. They want to be like, all right, let me check I need to check your troponin like right now. And that's why, because if they're having an active MI, like they are literally like the cells are actively dying, troponin is going to be elevated. If that's not happening, and this is just like another, like this is unstable angina, for example, that's what's causing the chest pain, troponin is going to be negative. And they can kind of take a breather and be like, okay, you're not having an MI. We have to fix what's going on, but we have a little bit more time. And that's why troponins are the gold standards. I mean, I know that they still do EKGs on people that come in with like chest pain, but like they do a troponin like immediately because it's like that'll tell you if they're having an MI or not. Okay. So patient with an acute coronary syndrome, like I said, they'll do kind of these at the same time, but whatever. So like they'll do an EKG. If we have transmural ischemia, so a total complete occlusion, you'll see ST elevations on the EKG in specific leads. Again, it's going to tell you where in the heart is that MI occurring. And then you have to do PC. You can only do PCI for this, and that's why they like to know because that's going to determine what treatment it is. If there's not an ST elevation, like I said, there can be an ST depression, there can be a T wave inversion, or it can just look completely normal, but they still have this chest pain. That would be like a subendocardial ischemia. You're not going to be able to visualize this, but that's what's going on. There's subendocardial ischemia happening. So then they check the cardiac markers. So the main two you want to look at, like I said, troponin, that's like your gold standard. And then CKMB, AST, LDH, you can do myoglobin. If those are positive, that means active MI. Negative, that's unstable angina. And like I said, it just kind of helps them like buy a little bit more time because now it's like, okay, like they're not actively losing tissue, like they're not actively losing cells right now.
So,
Oh yeah.
I'm so sorry.
No, good.
And STEMI, you would still see the enzyme elevation, no?
Yes.
Okay, cool. So just that if it's negative and unstable. Gotcha.
Yes. So this is either a STEMI, so ST elevation, or NSTEMI, non-ST elevation. But the NSTEMIs and unstable angina, why people tend to confuse those two a lot is because unstable angina, your EKG looks normal. NSTEMIs, your EKG can look normal. It depends on like how much ischemia do you have. So what's really going to help you differentiate between like an NSTEMI and unstable angina is those markers, is those cardiac markers. Because they present almost exactly the same, and I guarantee you on any test you take, they're both going to be like answers in like a multiple choice because they present so similarly. Pericarditis, this is like another need to know, like, and it's not so. I don't get got. I'm gonna say don't get got, but actually don't get got because I know when you're like gonna be looking at EKGs now and you're gonna be like, oh wow, like your eye's gonna be drawn to like something that looks off. Like if you're here, you're like, wow, like these ST segments are definitely elevated. Wow, here they are elevated again. You're like, wow, here they are again. You're like, oh, it's a anterior like middle wall MI. Like look at every single lead. So if you see ST elevations, look at every single lead. First of all, see if there's a pattern, see if there's any of the, because especially when you, like at this level, they're not going to give you ST elevations in random leads. They're going to give you ST elevations in like these leads because they're trying to lead you to one of these heart MIs. So if you see one in AVF and you know for sure like that's an ST elevation in AVF, look at leads 2 and 3. Like look to see if there's also ST elevations there. If you're looking at the rest of the EKG though, and you just see ST elevations in every single lead, it's not great in lead 3, but just every other lead has like a very obvious one. You should think of pericarditis. So that's what this is. Those are your diffuse ST elevations. Literally, maybe not every lead, but almost every single lead, you're going to have ST elevations. And then what's going to kind of be icing on the cake is they're going to say they have chest pain that feels better when they lean forward. That's very, very specific for pericarditis. Okay. Another common EKG that you should recognize is torsade. Another name for torsade is polymorphic VTAC. So it's like twisting around a point. If you were to draw like an isoelectric line, I'm not going to draw it on the whole thing, but it just looks like it twists around this isoelectric line. And this is ventricular tachycardia. Like it's not great. Any prolongation of the QT interval can predispose a patient to torsade. So they can have a long QT syndrome. Romano Ward, I think, is one. Like there's the random ones that Anki mentions. Those can precipitate torsade. The class 3 antiarrhythmics can precipitate torsade. The class 1As can precipitate torsade because all of those prolong the QT interval, and you'll see that. Hypokalemia can cause torsade, which is interesting, and then hypomagnesemia can precipitate torsade. And I bolded this because the treatment actually for torsade, even if it's not hypomagnesemia that causes it, the treatment, if you see this, is just to give magnesium. Okay, that's just the treatment for torsade. And even when in the I even called magnesium a class 5 antiarrhythmic because it does have this antiarrhythmic function. It's a treatment for this arrhythmia. So that's why it's considered an antiarrhythmic. So it doesn't matter what the cause, hypokalemia can be the cause. You don't get, it's like a trick question, right? It's like this patient has hypokalemia, now they have torsade. You don't treat with potassium, you treat with magnesium because you always treat torsade with magnesium. So this now hypokalemia. So hypokalemia, you look for those U waves. So how I've seen questions with hypokalemia is they'll talk about how like maybe the patient's on digoxin or something like that you know causes hypokalemia, and then they show you an EKG. Or it's like patients on a heart failure medication. Now this is what their EKG looks like. You're like, oh, this is hypokalemia. They're on, and it's like, which drug are they on? They're on digoxin. It causes hypokalemia. That's like a need to know about digoxin. And now you see these U waves in every single lead. That's like okay. So the U wave, just remember U comes after T in the alphabet, T, U, right? So that's the point of the U wave. It's just this little bump after the T wave, but it's before the next P wave. I wish this did like one more so you could see it would be like this and then like another bump and then oh my God. Oh, it's not bad. Kind of.
It's a good one.
Not great. Not great though. There's like a double little peak. It's all right. But yeah, so keep in mind, like, it's going to be a little bit lower than a P wave though. So just kind of keep that in mind too. Like, don't think it's like this and then you're like, oh, that's just a P wave. It's fine. It's going to look like it's going to come a lot quicker after the T wave than a P wave should. And it's also going to be present in every single lead. It's not just going to be like in one and then you're like, oh, it's going to be in every single lead. Because again, hypokalemia affects the entire heart. It doesn't just affect like the anterior heart or the posterior heart. It affects the whole heart. Same with hyperkalemia, same thing. You have peaked T waves. So I actually like this picture because it shows, I mean, it doesn't give you every single lead, but at least it gives you all the precordial leads. So you can see in every single lead here, there's a peaked T wave. So it looks like a QRS complex, but here's the QRS complex. And then the T wave, instead of being a nice little thingy, is like this giant peak. That's hyperkalemia. And then it even says like, oh, there's smaller indiscernible P waves. That's just something else to like just keep in mind. Like this is not a P wave. This is a peaked T wave. They're usually very obvious. Like they usually are like this when I've seen them. And then this is just like, again, if you were to just look at an entire EKG, like kind of check out every single lead, but you can like this I think is a really good example. It's like here's your T wave, then there's like it looks like another wave, and then here's like a baby P wave, right? Even here's T, here's U, and then here's P. T, U, P. So just kind of like keep an eye out. Again, they're not going to be in every, like it's because just like it can't pick up every single lead all the time. But it just like with the STEMIs and STEMIs and the pericarditis thing, just like even this one, this only looks like there's only like one T wave, no U, that's fine. Just kind of like if they're in multiple leads, then you're like, okay. Same with usually the peak T waves, like I said, they're really obvious. Like this is super obvious. Like that's just very obvious that that's a peak T wave, but this is a peak T wave. Here's another one. Here's another one. They just shouldn't be this. They shouldn't be as big as the QRS complex. All right, Wolff-Parkinson-White. This is another one. This was the one that I had on my boards. I had Wolff-Parkinson-White on boards. They're really hard to see on EKG, I'm not going to lie. So you kind of need to use like the vignette to kind of help you with Wolff. They're so hard to see, like literally so hard. But what you need to know is that what the wave is that like defines Wolff, like the defining feature of Wolff-Parkinson-White is what's known as a delta wave. So this is just a little bit about Wolff-Parkinson-White. It's going to be I go into a lot more detail, in the PowerPoint from yesterday into the arrhythmia lecture. But basically, as you know now, Wolff-Parkinson-White, it's a global reentry circuit and it goes through the AV node. So it's an AV nodal reentry circuit. That's why a lot of the antiarrhythmics you can give are going to blunt this reentry pathway. That's what's happening here. So talk about it's a reentry tachycardia or like a bypass pathway, which it's not showing here, but you can also bypass the bundle of Kent. You can do whatever. But what's important to know is with Wolff-Parkinson-White, because we have this delta wave, so this delta wave is basically like, it's basically like starting the ventricular depolarization before it should be depolarized. So you're going to see a shortened PR interval compared to normal. So the dotted line is normal. With Wolff-Parkinson-White, the PR interval is going to be a lot shorter. And then they're going to have like this little swoop, like this little slanty instead of a nice, like beautiful, even if this were to be a Q wave, it would be still this, like, it would be nice and beautiful and flat, not like this little slope up into the R wave. And I have a picture here. This is how hard it is to identify the delta waves. Like, I personally think that this is so hard to see on an EKG if someone wasn't telling me. So if you ever see an EKG where it looks normal, but it says like this patient has like tachycardia and they have like they're a younger person that's having like this like, it feels like they're fluttering and whatnot, and it's not flutter on the EKG, you need to like maybe look at like where the QRS complexes start and see if it looks like it's dipping like this. Like it's not like a dip like that where it'd be like a Q wave. It's more of like a very like soft like swoop. Like that's kind of what they were pointing out here. Like a nice soft swoop. I still think this is really hard to see. But even here you can kind of see it. It's like a soft swoop. But again, I think that's so hard to see. It's just something to kind of keep an eye out for. It is what it is. Use the vignette to help you. A lot of the time, sometimes they'll even give you, like, they'll tell you the patient has an arrhythmia, which helps. But you should know that these are called delta waves. That's like another thing that they could, like, I could see them asking, like, oh, patient is diagnosed with Wolff-Parkinson-White, which is like the defining feature on the EKG. Like, can you point to it, or which letter is pointing to it? And it's just going to be this little swoop before the R wave. That's a delta wave. Okay. I know I wish I had a better way to help you figure out what Wolff-Parkinson-White. It's so hard. Like I people have to tell me to look for it to be like, oh yeah, that's a thing. Okay, AFib and aflutter. This is like another need to know. So this is again going to be every single lead is going to look like this. I have them to show you what it would look like a normal EKG. But remember, aflutter and afib, usually they don't say flutter and fib. They'll say like, oh, there's an irregularly regular rhythm. So remember, the first one is for rate, the second one is for rhythm. So aflutter is irregularly regular. Regular, talking about the rhythm, means that even though, and this is kind of what's tricky about flutter, is even though the rhythm is not this is not a normal rhythm, but it's not talking about normal. It's talking, is it regular or not? So is it in every single time you see it? And it is regular because it's the same pattern every single time you see it. It's not normal, but at least it's regular. It's consistent. You can think of regular as being like consistent. The rate, though, is still irregular with flutter because rate is the distance between the R waves. So from here, this is like whatever. This is a long line, then it's a short line, then it's a short line, then it's a longer line, then it's a long. So it's irregular. AFib, both are irregular. So we have an irregular rate, we have an irregular rhythm. So the rhythm is inconsistent, like it's inconsistent from beat to beat, and the rate is inconsistent from beat to beat. Okay, so AFib, aflutter, those are like need to recognize. So if I showed you this, you would be like, okay, this is AFib. I will say AFib and third degree heart block tend to look very similar, and we'll talk about third degree heart block. So before you pick like AFib for sure, make sure it's not third degree heart block. Okay, and same thing with third degree heart block. If you want to pick third degree heart block, make sure it's not AFib. Okay, and sometimes you can use the vignette for that. But we will talk about heart block. But for AFib, what we're talking about, again, look at the distance between the R waves. These are irregular. Even if you're not sure, you'll be able to tell with this lead 2 at the very bottom, like just because it shows you the whole strip. This is not regular in between the peaks. And then even if you just look at lead 2, this is not regular. Like this is different. Like each beat looks different. Okay, so that's your AFib. Here's your flutter. So, what, and again, just kind of stick to looking at lead two. That's what I tend to do. I get confused if I look at the whole EKG. But if you look at just lead two, like here's your sawtooth pattern, your little like like that. There's your sawtooth, and then the this looks, well, I guess this looks kind of regular, but that's fine. That's fine. As soon as you see the sawtooth, it's flutter. This was actually one of my friends whose dad's was in the hospital had sent me this and was like, "Do you know what's going on with my dad?" So this is when he was in the ER, and she sent me a picture of his screen, and I'm like, "Yeah, it kind of looks like AFib." And I'm like, "That's because they didn't say what it was. They just had the leads on him." So here's the rhythm. You can see it's irregular, and this is again lead two. So just looking at one lead, like this is irregular, and then the rate, the distance between the R waves was also different. It's also different. So I'm like, that kind of looks like AFib. And then when they admitted him to kind of see what was going on, they diagnosed it with AFib. So I just thought that was cool. I was like, look at that. I can put that in my PowerPoint.
That's it. You know
Yeah,
stuff.
I crossed off the name, so I don't know. Not that you guys would do anything. But anyway, okay. And then heart block. So heart block, these you could 100% see any one of these on your boards. If I were to pick an EKG to put on boards on an exam, I would pick one of the heart blocks because you can tie in like physio, you can tie in pharm, you can tie in a lot of stuff with heart block. So we are going to talk about heart block. I talk about heart block a little bit in the arrhythmia one, but it's fine. It's not a big deal to go through it again. But basically, heart block, I think of the conduction system, like so the conduction system of the heart, I think of putting a big X through the AV node. That's basically how I think of heart block. So there are 3 types of heart block. So we have first degree, second degree, and third degree, and then there's 2 types of second degree. So there's a type 1 and a type 2. So we're going to go through all of those. So what is heart block? So heart block is basically when you have too slow of conduction going from the atria to the ventricles. And this is just like something that's like a physio fact is you should know that the AV node, one of the big roles of the AV node, and if I go back here, one of the big roles of the AV node is to slow down this impulse. It wants to slow down this impulse. And the reason why is because it wants to allow the ventricles to fill with blood. So it wants to give before like the atria contract again, it wants like before the ventricles contract, it wants to make sure that the ventricles have time to fill up with all the blood from the atria because it doesn't want to contract the ventricles before the atria empty out all of its blood. So that's a huge goal basically of the AV node is to allow for ventricle filling. So that's what it does. A lot of the times with heart block, especially first degree, people don't even know that they have it. It's like an incidental finding. My brother has first degree heart block, which he didn't know until he like got an EKG one day. They're like, you have first degree heart block. He's like, oh, okay. You will see this, and I talked about this yesterday, but I'll mention it again because it's good to look for in vignettes. Athletes. So athletes tend, if they want you to think of heart, like especially first degree heart block, think of athletes. And the reason why is because athletes who are like, my brother was an athlete and he actually got diagnosed with this when he was playing college football, just like going to the getting a regular physical. But basically with athletes, they're always exercising. Like they have to shoot out so much cardiac output to get to their organs because there's always exercising. So it's kind of like the body thinks of this as being like, hey, like let's slow conduction to the AV node. So every single time this athlete beats out blood, it beats out more because it's allowing even more time for ventricular filling. And that's why they say like a lot of the times athletes can have, if you're a really intense athlete, you can have a normal heart rate of like 40. And my brother, when he was playing football, my brother's heart rate was like 42. I'm like, are you alive? Like, I'm like, are you like, I know, I'm like, are you like living? Like your heart rate's 42, like resting. I'm like, are you gonna just pass out on me? But that's why. It's because like his body like thought of like his neurological system was like, hey, like let's have the AV node slow conduction down even more so that you can pump out even more blood with every beat. How about that? That'll make us work less. Like it'll make the heart work less. But then usually it's not a big deal, but it can cause like a slow heart rate. Obviously your heart rate's 40 to 45. So you can get like tired more often. You can feel dizzy when you're standing up. That's something he always had though, and he still has that, even though his heart rate's not that low anymore. I think it's like 55 now. So it's still not great, but he'll like be laying down and he'll stand up and he'll get really dizzy sometimes, and that's probably from the heart block. If it's more serious, so this would be like more of like the third degree heart blocks, like the second and third degree heart blocks, that's when you would actually put them on like maybe an antiarrhythmic or like even do like let's put a pacemaker in to kind of take over from that AV node. Okay. So just something to keep in mind, especially with the heart, the first degree ones, look for athletes. So we'll talk about first degree first. Here's your normal. I put on here like what the normal intervals are. And I only did this because I didn't realize it until I was in dedicated, and I had to know what the milliseconds were for these intervals, because they, instead of saying like, oh, the PR interval was prolonged, it would say, oh, the PR interval is 220 milliseconds. And I was like, damn it. I was like, I do not know what a normal PR interval is. I was like, damn it. So I put both milliseconds and seconds because I got questions on UWorld as well with seconds. And I know it's like easy math, but like, my head. So just keep that in mind. I don't know if you need to know all of these. Maybe the QT interval you should know as well, because I would see questions where they would be like, so normally a QT interval is like 360 milliseconds. So sometimes I'll see questions like patient has like a QT interval of like 450 seconds, and then it would be like, oh, they have either a long QT syndrome or they're on like a type 3 antiarrhythmic or a type 1A antiarrhythmic or something like that. Okay, so it's like, what is this patient predisposed to? Torsade. So just little things to keep in mind. I would just know that. I would know your PR interval is 160, and then your QT interval is 360. Easy enough. But what's weird is first degree heart block is not diagnosed until it gets greater than 200. So normal is 160, but you don't actually diagnose first degree heart block until it gets to greater than 200 milliseconds, like the PR interval. So even if you have someone with a PR interval of like 180 milliseconds or 190 milliseconds, it's not first degree heart block. It has to be over 200. Okay. And then something to mention, and this will come more into play when we talk about the other types of heart block, all P waves are conducted, which means every single P wave is going to be followed by a QRS complex. So really, if you're looking at this EKG, and this is something that like, this is another one kind of like Wolff-Parkinson-White, like it might not look weird if you don't know to look for it. So it might look normal like this, because the EKG is going to look basically normal. It's just the PR interval is going to be longer than normal. So if you're not, and it's going to be in every single lead. So it's not going to look like one lead is off. So it's going to draw your attention there, just like Wolff-Parkinson-White. So it's kind of got to be something that you look for. So look for athletes that are like, having like dizziness, like blah, 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 whatever. They're like on antiarrhythmics, whatever. They're on like a beta blocker, calcium channel blocker, something like that. So this is how it should look. A normal PR interval, it's like kind of tiny, but on like a heart block, it looks bigger. Okay, that's all it is for first degree. Second degree, now we increase the severity a little bit more. Now we're at second degree heart block. So there's two types. There's type 1 and type 2. So it's like Mobitz 1, Mobitz 2. Mobitz type 1 is also called Wenckebach. Just absolutely ridiculous name. But so there's two types of type 2, and a lot of the times you do need to know like, oh, this is a type 1 second degree heart block, or this is a type 2 second degree heart block. Both of them. So what kind of makes it now go from like a first degree to a second degree is with first degree heart block, all of the P waves are conducted. So there's every single P wave is followed by a QRS complex. With second degree, now there's some sort of droppage of a QRS complex. So just sometimes a QRS complex just won't be there. So this is second degree Mobitz 1. So this is your Wenckebach. I would know all the names. I have seen different things, especially like using ComBank. I mean, I know I was using ComBank, not ComQuest, but ComBank would call it Wenckebach, but like UWorld calls it Mobitz 1. So just know all the names. With Mobitz 1, so your Wenckebach, some of the P waves are conducted, some of the P waves are, some of them are not. So this P wave conducted, this P wave conducted, this P wave conducted, this P wave did not conduct. I want to point out that this is going to be, you really have to use the vignette though to help you, because this, if you're not careful, this can look like a T wave and then a U wave. So you really kind of have to like be like, what makes the most sense here? Like, remember with U waves, every single lead is going to have like a U wave. It's going to like, it's not just going to be like a random QRS complex is missing. Like, it's like, this looks really weird. Like this this rate looks a lot different than like this rate because there's a whole ass missing QRS complex. So just keep that in mind. I have seen people get confused with like, they're like, oh, this is a T wave, then a U wave. And I'm like, no. And then they pick the entirely wrong answer. So just keep that in mind. But the difference between type 1 and type 2 of of second degree, so Mobitz 1, the PR interval is going to get progressively longer each time before dropping a beat. So with type 1, it's kind of like it's giving you like an indication that it's going to drop a beat. Like, okay, PR interval is long here, and then it's longer for the next beat, then it's even longer for the next beat, and then the QRS complex drops. So it's like a little foreshadowing, like, hey, something bad's going to happen, and then it does. Okay? So it's like it gets longer, and then it drops a QRS complex. Whereas Mobitz 2, it doesn't tell you. No foreshadowing whatsoever. Just dropped complex. You're just like, okay, like weird. Like, and usually you can pick this out, again, looking at the rate. So you're like, okay, that's normal, that is not normal. And it's just every now and then. It's not like an irregular rate the whole time, like with AFib. This is like, it seems like it's consistent. It's like, you know what I mean? It's just kind of like, okay, there's just like a missing QRS complex. But then you look at the PR interval and it's normal every single time. You're like, okay, this is like a type 2, like a Mobitz 2 type 2 heart block. Okay. So I just think of like Mobitz 1, it's like, it's the first one. So it's trying to be nice. It's like, hey, like something bad's going to happen. And then Mobitz 2 is like, nope, it's just going to happen. No, absolutely no warning whatsoever. Okay, so that's Mobitz 2. And then Mobitz 3 complete. This is what I was telling you, can look very similar to AFib. And I know it doesn't really look it right now because it's just like 3 beats or like 5 beats. But just keep in mind, like because you can tell, if you look at an EKG, you're like, that doesn't look normal. And you're thinking, okay, is this AFib? Like what's going on here? My thing is when I look at an EKG and it looks just so out of whack and it's like, I don't even know what's going on here. Usually it's third degree heart block. Okay, so, and the reason why third degree heart block is complete heart block. So it's exactly how it sounds. The atria and the ventricles absolutely have nothing, like they just don't interact with each other whatsoever. So the ventricles are doing what they want, the atria are doing what they want. They say there's no impulse control. So it's kind of, again, like the ventricles and the atria are just doing whatever the heck they want. So you'll see random P waves, like this is a P wave, this is like a P wave, and then this is like a T wave, and then this is a P wave, and then this is a T wave and a P wave. So it's just kind of like, they just kind of do whatever, but there's no rhyme or reason to it. Okay, so that's your complete heart block. Again, looks very similar to AFib, so kind of use like the vignette to help you. Another thing that they can do is, this is back from when we were learning about, this is actually, I think from first year, when we were learning about the Wiggers diagram, and we talked about the venous pressure pulse thing, and I talked about Canon A waves. Here's your Canon A waves. So your Canon A waves, complete heart block. So total dissociation. So it's not just heart block, it's total dissociation of heart block. And if you can remember from this, like this wave, the A wave is atrial contraction. So normally when your atria contract, it doesn't have to contract that hard because the mitral valve's the tricuspid valve's gonna be open. So it doesn't have to contract that hard. At least like the sensor that's sensing the backflow of blood is not that high. But when you have something like complete heart block where the atria are doing whatever the heck they want and then the ventricles are doing whatever the heck they want, the tricuspid valve might be closed. So it tries to beat, nothing happens, like it can't get through. So it tries it again and it can't get through because it's like, it's trying to contract against a closed valve. So you can see that sometimes they'll give you a little hint and say like, oh, there are Canon A waves, or they'll show you this tracing and be like, okay. All right. So this is when I say like use your vignette to figure out, and here's your micro plug, but this is like when I'm saying like use your vignette to figure out what's going on. I've really only ever seen third degree heart block questions with Lyme's disease. So and it's one of those ones that they can just show you an EKG and be like, what's going on with the patient? But it'll say like, oh, the patient, went hiking. Like they went hiking and now here's their EKG now, and it's going to look like third degree heart block. And you're like, okay, that's Lyme's, that's because of Lyme's disease. So since you guys need to know micro this year, Lyme's disease the bacteria is Borrelia burgdorferi, and it's a spirochete bacteria. It causes a lot of weird stuff. We know that a lot of the spirochetes cause weird stuff, but one of the things that it can do is cause third degree heart block. And then that's what happens. Like if you just kind of let it go, you have the bullseye rash, and if you kind of let it go, you can get heart block from it. Here's the heart block poem. I don't know if you guys have heard this or someone brought it in for an LI. This is what I use. I still use it to this day. So if first degree heart block is if R is far from P, then you have a first degree, because the only thing wrong is the P wave and the PR interval is longer. Wenckebach, so type 1, so Mobitz 1 of a type 2, longer drop, that is called a Wenckebach. So your PR interval gets longer each time before you have a drop beat. That's your Wenckebach. Your second degree, Mobitz 2, is if some P's don't get through, then you have a Mobitz 2. So again, with this one, you don't have like an indication that anything's going to happen. You just have a random drop beat. And then finally with third degree, if P's and Q's don't agree, then you have a third degree. Hopefully that helps you. Longer drop. Okay. And then finally, the last thing that they can ask you to do is axis deviation. So a throwback from first year, but they can ask you axis deviations. But hopefully it makes sense now because you guys know EKGs. All it is like if you were to put like three-dimensionally, so put all the 12 limb leads on someone. So put all the limb leads and the precordial leads. Well, not even the precordial leads. Just put all the limb leads on someone. So 1, 2, 3, AVF, AVL, and AVR. Just put all of those in like a three-dimensional space. It would look like this. So it would literally look like this. And what I tell people to do is like just draw out the limb lead. So like lead 2 goes from like top right to bottom left. Lead 3 goes from top left to bottom right, and then lead 1 goes straight across, and then draw in the other ones, AVL, AVR, and AVF, okay? Now we have like a plane, and then you can label it like, okay, 0, 30 degrees, 60 degrees, 90, so it's positive in this direction, and then it's negative in that direction, okay, up until here. All right, so that's kind of what I just said. The axis is basically if you were to sum up all of the depolarization vectors by all of the myocytes in relation to every single limb lead, that's your normal EKG axis. So normally, and yeah, so I put the slide back on here just to remind you, like, okay, lead 1 is straight across, lead 2, lead 3, and then AVR, AVL, AVF. If you were to add up all of the vectors from all of these axes with where the heart is, your overall vector would be, again, lead 2. We've talked about this many times. So it's going to be like from top right to bottom left. That's going to be your normal axis. So it's going to be somewhere around 60 degrees. But notice that your normal axis can be anywhere from -30 all the way to +90. And again, this is what I'm talking about, how like some people's hearts are just like, it's like the idiosyncrasies of hearts. Like some people might just have like a thicker heart compared to others. Maybe they're going to be closer to like -20, and that's still normal. It's still considered a normal axis. Okay. And all it's saying is like normal people's hearts go from the top right to bottom left. They sit in the person's chest at a 60-degree angle down. Okay. But they can sit anywhere between -30 and -90 or +90. Axis deviation. So if you add up all the summation vectors and now it's leading from -30 up to -90 up here, so it's in this direction, that's going to be like a left axis deviation. So this is telling this, like if you were to see a left axis deviation, this means like the vectors are moving stronger towards like the left side of the heart. So it's like it's sending a lot more impulse to the left side of the heart. So think about anything that would require that. Like if you have left ventricular hypertrophy, that's like the most common one. You can even have a left bundle branch block. If you have a left bundle branch block, the heart's almost like, no, we need it to go through the left bundle branch. So it's almost like it's trying extra hard to send signals through the left bundle branch. If you have an MI, same thing. It's kind of like what we were talking about earlier. It's almost like it's overcompensating for having this MI. So that's a left axis deviation. A right axis deviation is the same thing, but the opposite side. Now it's pointing to the right side of the heart. So think about right ventricular hypertrophy, so like cor pulmonale. So you have like right heart failure because of like pulmonary hypertension or because of left heart failure. Right bundle branch block, an MI, the classic accidentally putting on the leads backwards because now everything just goes on the opposite side of the heart. You're like, oh no, what happened? So that's your right axis deviation. And then your extreme axis deviation is like it's the exact opposite way it should be going. So there's lots of stuff. Usually with this, it's like it's either extreme this way or it's extreme this way. So all the causes are usually like severe left ventricular hypertrophy or like severe right ventricular, like pulmonary hypertension causing right ventricular hypertrophy. And usually you can use like the vignette to help you figure out which one it is. Okay. So this is something that, I mean, you don't have to memorize. I'm going to show you a trick, which is really fun. But you should know how to draw this little pizza pie thing, and then you should have it labeled with the axes and then what all the values are, and then just understanding normals between here and then the left axis, the right axis, and then the extremes. All right, here is my method. I don't know if has anyone ever taught you the quadrant method trick? Oh, you're in for a treat. I'm so excited. All right, so we're going to teach you how to determine axis deviations just using EKG. So basically, how you do this is all you have to do is look at lead 1 and lead AVF. Because if you think about it, it should be around 60 degrees. The axis should follow lead 2 like perfectly. So in theory, a normal axis most of the time should be between 0 degrees and between 90 degrees. So it's going to be between lead 1 and lead AVF, right? So if we were to like look at it here, so here's lead 1. Lead 1 is going from top right to top left. It's like a vertical line. No, that's the horizontal line. And then lead AVF, while it's not a bipolar lead, you can imagine if the heart's up here, AVF is almost like a vertical line down from the heart. So I bring this up because here's the first thing that you do. You draw a circle and then draw on your lead line. So we're gonna have 2 circles. So we're gonna have one for lead 1 and then one for lead AVF. And this is for the lead because I'm trying to mimic the lead on the body. Then just draw a perpendicular line to that lead. So lead 1, I'm going to have a vertical line. Lead AVF, I'm going to have a horizontal line. And then based on the lead, so again, because like these are this is a bipolar lead, this is unipolar. With the bipolar lead, with lead 1, the negative sign is on the left side, and then the positive side is on the right side. Over here, it's kind of like, yes, there's technically not a negative side, but the positive side's on the bottom. So we have positive and negative, okay? And then label, so 0, positive 90, positive 180, and then negative 90. So label your circle, okay? So that's the first thing that you have to do when you want to, if it asks you for an axis, this is the first thing that you do, is you draw one circle for your lead 1, one circle for your lead AVF. Next, what you want to do is look at the QRS complex in lead 1 and then in lead AVF. And then you want to determine, is it positive, negative, or equiphasic? So what that means is positive means if you were to draw, and like that's why I like this picture, if you were to kind of like draw a line splitting the QRS complex like along the normal baseline, is it more above that line or is it more below that line, or are they like equidistant away? So for this one, I would say this is positive because there's more up here than there is down here. Like this is bigger than that. This one looks completely the same. So like this distance looks the same as this distance. And then this one is much bigger down here than here. And you're just comparing the R and the S waves basically. And you're looking at if it's positive, R is bigger than S. If it's negative, R is less than S. Okay? So once you determine that, you're going to actually, I skipped a step. You're going to basically fill it in on your circle. So you're going to look at lead 1, look at its QRS complex, and then fill in like, okay, was this positive? Was it equiphasic or negative? And let's say it's positive, you would fill in the positive side. On your AVF circle, if it's positive, you would fill it in, you would color in the positive side. Okay? And then when you do that, you should have an overlap between the leads. So I'll show you this example. So we'll do it together. So this lead here, this is lead 1. Is this positive, equiphasic, or negative?
Positive.
Yeah, good. Positive because the R wave is bigger than the S wave. So I'd shade in positive. Then I look at AVF. What about this one?
Also positive.
Mm-hmm. Because R is a lot bigger than S. So shade it in, and then you overlap it. So if this were to be like a quadrant, like 1, 4, 2, and 3, same thing here. 4, 1, 3, and 2. Where on these 2 circles do they overlap? They overlap right here. So if you were to draw it on like a single quadrant thing, that's from lead 1, that's from lead AVF, that's where they overlap, that's where your vector is. So this would be a normal axis. Isn't that fun? The quadrant method? Love the quadrant method. Because you don't need to go into that much detail. Axis deviations don't need to be like a crazy thing. So here's a little chart, but you can just like you don't have to memorize this chart, you just do it. And then you can just fill it out yourself. And that's kind of why I liked the little draw this line, then draw that line, draw the perpendicular line, and then you can kind of figure it out on your own. You don't have to memorize positive is this, positive negative is this. But keep in mind, it's the only time that this like fails is because remember that it can be normal, like your normal axis can technically be normal up to -30. Which is technically, it's not really accounted for with this method. So that's why they say here is if you get a result in this quadrant 4 up here, I think it's quadrant 4, yeah. Just keep in mind it still can be normal. So even this is like, it's a possible left axis, but it still can be normal because -30 is in there, and that anything before -30 is still technically normal. All right. And then I wanted to do a really quick note on bundle branch blocks because bundle branch blocks tend to get asked a lot. So typically with bundle branch blocks, you see like a widened QRS complex. So my question is kind of like, why? Why would you see a widened QRS? And the reason why is because a bundle branch block is exactly how it sounds. One of those bundle branches gets blocked. So it's kind of like there's going to be delayed ventricular contraction on one side. That delay is going to manifest overall on the whole EKG as being it's taking longer to depolarize. So that's kind of why you would see like a widened QRS. And then like the more fancy scientific terms, conduction through the affected ventricle must now spread from cell to cell rather than like rapidly through the bundle. Because the bundle is just like this bundle of fibers. So if it gets like blocked, it's not like the body just like stops. It's just like, oh, we need to find another way around. So that's what I'm saying. Like it's going to take more, it's going to send more energy, like more electrical signal to whatever side that is. So that's why like you can see a left bundle branch block is having a left axis deviation. A right bundle branch block is having a right axis deviation. It just doesn't go through the bundle anymore. It just spreads, it just sends the signal cell to cell. So it just, that, again, that's not as efficient. That's why normal people's hearts don't do this. And that's why normal people's hearts go through the bundle. But if there's a block, they have to go around it. Takes longer. That's your widened QRS. It takes longer for the QRS complex. It takes longer for the ventricles to depolarize. Okay. And then I also look for notched QRS complexes for bundle branch blocks. And the reason why too is because just by definition, one side's going to be totally fine. One side's going through the bundle. So one side's going to be a lot quicker than the other side. So on an EKG where the QRS complex is all of ventricular depolarization, it's almost going to look like one side is happening before the other. And then you can see like notching to the QRS complex. So just as an example, this would be like a left bundle branch block. Just you can note it without even looking at specific leads. Just look at the QRS, like they're very wide. Like these are just very, very wide. Like that's why I hate drawing when I draw QRS complexes because I draw them as bundle branch blocks. Like look, that's a bundle branch block. But like a normal QRS complex should be, and if I just scroll really fast all the way back to the beginning, that's how a normal EKG QRS complex should look. It should just look super, super thin, which I just can't seem to draw. Come on. All right, well. But if you have a bundle branch block, just by definition, they're going to be like thicker, basically. Where are we? Okay, yes, good. Okay, and then a lot of the times, and this is not why this is not in a common EKG. This was not in those slides because a lot of the times they will not give you like a bundle branch block and be like, what is this? It'll be like very just supplemental to like whatever the vignette is. Or they'll ask like a physio question about it, or they'll give you like an axis deviation question. So me saying like, okay, notched R waves in the lateral leads, you don't have to memorize this. Just know that these are the lateral leads, but it's more so like just noticing right off the bat that the QRS complexes are just super, super, super wide. And then you can figure out like, is it a left bundle branch block or a right bundle branch block? The right bundle branch block, they like this is actually like a common thing. Actually, before COVID, when we actually dressed up for Halloween. Well, we didn't all dress up, but my group wanted to do, we were in our cardio renal block, right? Because that's Halloween. So my group wanted to dress up as cardio stuff. And one kid in my group had bunny ears on. They put bunny ears on. And that's why they're like, what are you? And it's like, oh, I'm a right bundle branch block, just to be
That's
cute.
right.
I'm like, that's so cute. I should have thought about that. But they wore bunny ears because of this. So like while it's like kind of like I think this widened QRS is a little bit harder to see than the left side, but it's still there. Like if you don't see the little bunny ears, like the notching, it's still pretty like that's pretty wide. Like this is pretty wide for a QRS complex. But you can notice from the left side, this looks a lot more like rabbit ears than the left bundle branch blocks. They straight up just look like little rabbit ears, like little rabbit ears. And it's just because again, it's not going to be as tall as the left side because the right side's not as intense. Like the right side's not as thick as the left side, so it doesn't look as notched as this. It more so looks like two separate peaks. So that's your bundle branch blocks. Okay, and then questions. Oh man, I did the wrong one. Hold on, guys. Oh man. Oh, did I save the wrong one? Did I send you guys the wrong one?
No, I think we just have this one.
Oh no, are the questions gone? Wait a second. Stand by, stand by. What the heck? Oh my gosh, I don't know where the questions are. Well, do you guys have any questions while I try and search for these?
I do.
Okay.
Discussing right and left bundle branch blocks. I recall Dr. Ryan saying, like, you look at these two leads, and if
Yeah.
it's like a positive deflection versus negative, that's how you know if it's right or left.
Yeah, you don't have to know that.
No, don't even bother. Just do this
No,
thing.
I learned that like I went to detail at that point. Like again, when I was studying EKGs in so much depth, I knew all that. I've never seen even on UWorld, I've never seen a question about how to like knowing if it's a right or a left bundle branch block.
So if you suspect that it is like just rabbit ears are for the right, and then
I mean, you
you
can look at the more like I actually do have it on here, like I have no idea where I'm not, so upset. Okay. You can do like look at the anterior leads for right bundle branch block, like V1 and V2. They will have the rabbit ears, but you can see rabbit ears in all of them, versus the lateral leads for a left bundle branch block. So like 1 AVL and then V5, V6. Which is on the PowerPoint, but yeah, their bundle branch blocks are like not gonna be on like step 1. They would be on like a future, like more clinical exam.
cool.
I will have to locate the questions and send them to you. What I basically was, because I have no idea where they are, and I don't want to like waste your guys' time trying to find them. They're probably in like a PowerPoint that I saved like elsewhere. I just I'll have to like find an old drill. Maybe I just deleted them. I don't know. But I don't really know. I don't know what happened. Oh wait, maybe is this it? Hold on. Last ditch effort to try and find these. Haha! It worked! Can't believe it. Oh wait, you guys can't see my screen. I'm pumped. All right. I don't really understand what happened though. I just found like another, don't look. All right. I just found like another PowerPoint that was named the same thing in the same folder. So I don't really know what happened. All right. But yeah, so don't go into too like especially with EKGs, I brought even in like a board style question. A lot of the times even with the board style stuff, it's going to be a lot of using the vignette to help you. They will very, very rarely ever just show you an EKG and be like, what does this patient have? Unless it's like Wolff Parkinson White, pericarditis, or like an infarction where you can use the limb leads to figure out like which infarction they have. Like, is it an anterior wall infarct? Like, is it 2-3 AVF, inferior wall infarct? Something like that. The bundle branch blocks was just something I always get questions on bundle branch blocks. I feel like Papa also like mentions bundle branch blocks a lot, but he really, at least for us, he did not ask bundle branch block questions. If it makes you feel better, you can learn the Dr. Ryan way for this exam. But I did not have a bundle branch block question like about EKGs on my boards at all. And to my knowledge, other like second years haven't told me they had bundle branch block questions.
Very cool.
All right, y'all, what's the axis? Here, I'll help you out. No, actually, I'm gonna make you guys do it on your own.
This should be normal.
What'd you say?
Said normal.
Okay. A vote for normal.
So for lead one, it's a positive. No, it's like P graded, so it's a positive. So it's going to be your quadrant 1 and 4. For 8, yes. No, I thought this was AVL, not AVF.
Ah, there you go. Yes, good.
Yes,
I'm
ignore
glad
that.
I got you now.
Actually, that's a great question. What if it's
You'll never ask this, but
Okay.
you'll never ask this.
I was like,
It's good. It's just to kind of get you thinking about, basically to get you thinking about this picture, to kind of know like all of the normal axes are going to be normally, besides like this amount here, they're going to be between leads 1 and lead AVF. So technically, you can just look at 1 and AVF and see if it's going to be between there.
That was silly, but that was good.
No, it's good. I'm glad I got you. Yeah, AVF. So you draw your little circle with the way that the lead normally goes, draw your perpendicular line, label it. This is positive, so we fill in the positive on this side. If we look at lead AVF here, remember that one's up and down, so we draw a perpendicular line and then positive, so that's going to be positive here, and then they overlap and it's right here. Great. All right, next question. And let me know when you guys are ready to see the EKG. I'll go to it.
Marathon runner.
Okay.
Christina, I just want to say that I'm still very blown away by the ischemia. The transmural ischemia. I don't know why, but that was cool.
Because it's so cool. It's not like an ST elevation, It's technically like everything else is just lower. It's like it's lying to you.
Yeah, but yeah. Still thinking about it.
I'm so glad. I'm literally so glad you're so happy, because I was so happy when I learned that. I was like, that's so cool. Oh my God.
And also the ischemia portion of it. Like when you have a transmural ischemia, that just brings that just hyperpolarizes everything. But when you have a
Subendocardial.
subundo, yeah, and it's still
And
dead.
isn't it
But
cool too? No, it's cool because it's cool too because now just knowing that you can now just apply so many other things to it. Like now you know you can't give
yeah,
like a antiarrhythmic for, and that's why a treatment for complete occlusion is not, oh, just give them a beta blocker, like just put them on a beta block. No, you need to do a PCI because it's not going to work on, like
right.
antiarrhythmics are not going to work on that.
But
It's kind of
just
cool.
wanted to say it's very cool.
I'm so happy. Oh, did you guys answer? I should probably pull up the chat.
Should I
Well,
type it?
Riley answered, so if you want to talk it out.
No, I'm good. D, Mobitz type 1.
Oh, okay. So we have D and we have G. We have, all right, chat. You guys have to chat now. Tell me with the vignette. Start, oh, start with the vignette. Tried to move you guys out of the way.
So we have
Anything notable in the vignette?
so I'll go on, Riley.
Oh, sorry, did not realize I was muted. Muted. He runs.
Okay.
Dad clearly had an MI of 42, which is something we are concerned about. And EKG.
Okay.
I thought I saw a PR. You know what? You are right. The QRS does drop, and it's QR longer drop. So Vanessa, I think it's D.
Yay. Yeah,
I
this
would
is
have
like
gone.
this was a
I'm
good
sorry.
example of like they were tricky. They were so tricky saying he was a runner. A lot of the times though, and that's something that's good to kind of point out here, a lot of the times first degree heart block can progress to second degree. And remember, first degree really doesn't, like, this guy didn't come in for a problem. Like he came in for a routine health exam. Remember, it's like that's something that they like find incidentally on an EKG. Um, he might have had first degree and maybe it progressed to second degree. Like you don't know. It could have also done that. But a lot of the times, like first, second degree, those are like very like just incidental that you can find. They did try and trick you by saying he's a runner. So this was like you really had to use the EKG for this one. But yeah, very good. So longer drop. So that's pretty long, I guess. That looks normal to me, but I guess it's long. That's long. That's long. Drop beat. So then you're like, okay, that's a Wanky Bach type 1, Mobitz type 1.
I definitely would have gone first degree AB block though, because as soon as I saw marathon runner, I was like, oh.
Mm-hmm.
Then I saw that.
I think that's
Oh,
what
that was
they
me.
want people to do. It's like they want people to do that by seeing like the 8 mile runner. You're like, oh no.
That was good.
Yeah, and then I pretty much put, even with all the other ones that weren't wrong, I put Amboss's picture of how they draw all the um all the heart blocks and stuff. But yeah. All right. Sorry, these are just my questions. Not as good as Amboss.
Okay, this is good. Which part of the heart is the MI?
Okay. Good job, guys. Yay! Here's your ST elevations, 2 through AVF, inferior wall MI. Um, I used this picture specifically because it looks like there's like, you know, there could be like some ST elevations in these other leads. And I always tell people, like, when that happens, like, kind of just go off of like what's more obvious. Like, don't like, and that's, remember when I'm like, when we were, oh, actually, I don't think we didn't actually have much tutoring with hemonc, or we didn't tutor at all with hemonc. I always tell people, like, even with like the primary coagulation disorders, the secondary coagulation disorders, kind of like when you're reading the vignettes, it's like what does this sound more like? It might not be like perfect for like a primary coagulation disorder versus a secondary coagulation disorder, but it's like, what does it sound more like? So even something like this, where it's like, it kind of looks like there might be, you know, some ST elevations in some of these. Oh, wait, that's lead two. Some of these like other leads, maybe, or like ST depressions or whatever. What does this look more like? And to me, it's like this is non-negotiable, like 2-3 and 2-3 and AVF. So like that's what I would go, even though it's like, oh, well, it looks like there could be some other stuff going on. There might be, but a lot of the times with these EKGs, they're a little bit messier. So it's just kind of like go off of like what, and you guys both did it, but just go off of what you think it just sounds more like. Okay. It's just
Yeah, like V3 looked weird, but I wasn't like
right.
like you said, two,
Like
three,
2
and
through
AVF.
AVF, and then you're like, okay, well, V3 looks weird, but you're like, that doesn't fall into a category. So you're like, you know
Yeah.
what? Yeah. So that's the exact way to kind of approach this. All right. So this is part one. So dude has an inferior wall MI. You guys got that right. Put it here. Part two. So this is the same EKG. Nice. Good job, guys. Yeah. So a lot of the times they won't give you this nice little part one, and they'll just show you an EKG like this and be like, what corner? So very like third order reasoning. This is a very like, this is what boards loves to do. Boards loves to like just absolutely exhaust you by like being like, okay, well, first I have to see where's the infarct, like what leads have the ST elevation. Then what artery supplies that? But this is what artery is directly occluded. So I know it's the PDA, but that's probably not directly occluded. It's probably the RCA, because in 90% of people it's the RCA. But keep in mind, if they give you in the vignette somewhere a patient is a left-sided heart, this answer would have been LCX.
Mm.
So they can play a lot of stuff. They can do a lot of stuff with like the cardio just by something like this. Okay, but you guys both got it right, which was good. But just wanted to really quickly review heart dominance, because, you know, you always need heart dominance. But if you're just looking at the heart here, so here is the right coronary. So this is like looking just at the heart in the chest, basically. So the right coronary goes around, and then it kind of leads to the PDA in the back. This is the left coronary, and then it splits into the LAD and then the LCX. And remember, the right coronary in right heart people do that, and then the left circumflex in left heart people supply the PDA. So here's the back view, here's the PDA, well, here's the PDA, and even in this netter picture, it's showing a right dominant heart, so the PDA is coming off of the RCA. Notice too, in this question, I didn't put PDA as an option, because I think that wouldn't be fair, but just keep in mind that can happen, and when that does happen, look for hints in the vignette, like, oh, maybe they said something about heart dominance that I missed, or maybe they want like something more they want to, like, I don't know, they gave me like another clue of some sort, like a direct occlusion. Usually a direct occlusion, you're not going to have a direct occlusion of the PDA. A lot of the times it's like the RCA gets directly occluded. But just keep it, if they do that to you, just try and look for other clues in the vignette, because it's like the RCA and the PDA are basically synonymous in terms of like inferior wall MIs. Yeah. And then this was kind of like just another picture to show, you really do need to know this. It's like easy points if you know it, which you guys all seem to know. But RCA infarct causes your inferior MI. If you have an LAD infarct, this is your anterior and your septal. And then if you have like a circumflex infarct, that's more of like your lateral wall MI. So you can kind of add like another line to this chart. And so, okay, what's occluded? Usually it's the RCA, PDA, the LCX, and then the LAD for these two. So if you have like an LCX occlusion, usually you'll see the ST elevations in 1, B5, B6, AVL. And keep in mind too, you can have an anteroseptal MI, so because that's still the LAD. So you can actually have like V1, V2, V3, and V4 all have ST elevations. That's still the same artery that gets occluded, even though it's not like, just anterior, just septal. It's both because they're both supplied by the same artery. All right, last question. Come on, Riley, make me proud.
Oh, no.
Oh, Riley, I just saw the picture you sent in the thing. That's so cool. I love that. Inferior lateral anterior. I love that. I'm gonna use this.
It's not mine. I got it from the internet, but it's helpful.
Though. I absolutely love it.
But,
Riley, tell me what your answer means. Like, say it in words. Come
so
on.
3.
What's 3? Come on.
Like a right axis deviation.
Good. Okay. Yeah, so you guys both got it. Very good.
Redemption. I like that.
Like, what is 3? I was like, oh, this thing. Yeah, so good. So this is actually negative to start. So I wanted you to see one that wasn't just always normal axis. So this is negative, this is still positive over here. So when you overlap them, you're gonna have a right axis deviation. So this would be something like cor pulmonale, or like right heart failure, or a right bundle branch block, or an RCA MI, or something like that. Cool. That's it. Wow, 9 o'clock on the dot. When does that ever happen? Gonna stop. Oh, do you guys have any questions though before I stop recording? Any more questions, I should say?
No, this was really good.
Yay.